another underlying condition. All right, now let's talk about bowel obstruction. So this is one of the lower GI conditions where I want you to understand the sequence of what's happening physiologically, because once you understand that sequence, the manifestations and complications make much more sense. So a bowel obstruction means that intestinal contents and gas are unable to move normally through the intestine, and this can occur in either the small or large bowel. The obstruction can be partial or complete, and there are two broad categories. So we have mechanical obstruction and functional obstruction. So a mechanical obstruction means there is an actual physical barrier preventing the contents from moving forward. So think of something that's physically blocking, narrowing, twisting, or compressing the bowel. One of the most common causes of small bowel obstruction is postoperative adhesions. So after abdominal surgery, bands of scar tissue can develop, and those adhesions can pull on or compress portions of the intestine and create an obstruction, even years after the original surgery. Other mechanical causes include hernias, tumors, volvulus, and intussusception. A volvulus occurs when a portion of the bowel twists around itself, and the danger isn't that the intestinal contents can't get through. That twisting can also compromise the blood vessels supplying the bowel, and that's when the obstruction becomes particularly dangerous. In contrast, a functional obstruction, such as a paralytic ileus, doesn't involve something physically blocking the intestine. Instead, peristalsis eventually stops or becomes ineffective. And we see this commonly after abdominal surgery, but it can also occur with severe illness, infection, certain medications, particularly opioids, and electrolyte abnormalities such as hypokalemia. So with mechanical obstruction, think something is in the way, and with an ileus, think the bowel isn't moving. So what happens above the obstruction? So this is the part I really want you to visualize. Imagine that we have a blockage right here in the intestine. Food, fluid, digestive secretions, and gas continue entering the GI tract, but they can't move past that point. So everything begins accumulating proximal to the obstruction, and the bowel starts to distend. Initially, the intestine tries harder to move those contents forward, so peristaltic activity can increase, and that's why early in a mechanical obstruction you may hear high-pitched, hyperactive, and sometimes tinkling bowel sounds. That increased peristalsis also helps explain the classic colicky or cramping abdominal pain. The pain may come in waves as the intestine contracts against the obstruction, and as the obstruction persists and the bowel becomes increasingly distended and fatigued, bowel sounds can eventually become hypoactive or absent. So we're not memorizing that bowel obstruction always causes hyperactive bowel sounds or always causes absent bowel sounds. The findings can change depending on where the patient is in the process. So why does the patient become dehydrated? This is another important piece of the pathophysiology. So large amounts of fluid can become trapped within the bowel, and the patient may also be vomiting and unable to tolerate oral intake. That means fluid is being lost from the effective circulating volume. So the patient may develop dry mucous membranes, tachycardia, decreased urine output, hypotension, and electrolyte abnormalities. So even though the patient's abdomen may be full of fluid and distended, they can actually be intravascularly volume depleted. So that's an important concept. What do we expect clinically? So the classic findings include abdominal pain or cramping, nausea and vomiting, abdominal distension, and decreased passage of stool or flatus. And the exact presentation depends partly on where the obstruction occurs. So a more proximal small bowel obstruction may produce earlier and more frequent vomiting because the blockage is relatively close to the stomach. And with a more distal obstruction, abdominal distension may be more prominent and vomiting may occur later. And look at the distinction at the bottom of the slide. With a complete obstruction, nothing is getting through. So eventually the patient will be unable to pass stool or flatus, which we call obstipation. And with a partial obstruction, some intestinal contents may still pass. So the fact that a patient had a bowel movement does not automatically rule out an obstruction. Sometimes we see little bits of diarrhea, little pellets of stool, but they may still have an obstruction. So why can this become an emergency? So here's where bowel obstruction moves from a GI problem to a potentially life-threatening problem. So as pressure continues increasing inside the bowel, the distended bowel wall can compress its own blood supply. So venous drainage may become impaired first, which causes additional edema and swelling, and eventually arterial blood flow can also become compromised. And now the bowel isn't receiving enough oxygen and we develop ischemia. And if that continues, the bowel tissue can become necrotic, and necrotic bowel can eventually perforate. And once intestinal contents and bacteria spill into the abdominal cavity, the patient can develop peritonitis and sepsis and death. So think about the progression. We have obstruction that can go to distension with increasing pressure, and we get impaired perfusion, ischemia, necrosis, and then perforation, peritonitis, sepsis, and death. So that's the sequence I want you to understand. Now, which findings would make you more concerned? A patient with intermittent cramping and distension fits with obstruction, but if that patient develops severe or increasingly constant pain, significant tenderness, guarding or rigidity, fever, persistent tachycardia, hypotension, an elevated lactate, or other signs of systemic deterioration, it's much more concerning about something like strangulation of the bowel, ischemia, perforation, or peritonitis. Even a change in character of the pain can be particularly important. Intermittent wave-like pain can occur as the bowel contracts against the obstruction, but pain that becomes continuous and severe, especially with peritoneal findings, should raise concern that we're dealing with more than a simple obstruction. Diagnostics, so assessment starts with the patient's history, and one question I would absolutely ask is, have you ever had abdominal surgery? Remember, a remote surgical history matters because that risk for adhesions. We're also going to assess the abdomen carefully for distension, tenderness, bowel sounds, nausea, vomiting, and whether the patient is passing stool or flatus. Lab testing can help us identify consequences and complications. We're looking at a CBC, electrolytes, kidney function, and sometimes lactate if we're concerned about impaired perfusion or ischemia. So let's talk a little bit more about the labs, because there isn't really a single lab test that diagnoses bowel obstruction. Imaging is what helps us identify that obstruction. So while the labs help us determine what the obstruction is doing to the patient and whether complications may be developing, and we'll usually obtain a CBC, so the white blood cell count may be elevated simply because of stress on the body and inflammation, but a significant or increasing leukocytosis, especially accompanied by fever, worsening abdominal pain, or those peritoneal symptoms, makes us more concerned about bowel ischemia, necrosis, perforation, or infection. We also want to look closely at the patient's hemoglobin and hematocrit. Early in the process, these can actually appear elevated because the patient is becoming dehydrated and hemoconcentrated. So an elevated hematocrit doesn't necessarily mean the patient has too many red blood cells. It may be just telling us that they've lost a significant amount of circulating fluid. The CMP, or basic metabolic panel, is especially important because these patients can develop significant fluid and electrolyte abnormalities. Remember, they're often vomiting, they're not taking anything by mouth, and fluid is becoming trapped within the bowel. So even though we may see a very distended abdomen, the patient can again become intravascularly depleted. And because of that, BUN and creatinine may increase as renal perfusion decreases. So if I'm seeing an increased BUN and creatinine along with tachycardia, dry mucous membranes, hypotension, and decreased urine output, I'm thinking about significant volume depletion. And then we have the electrolytes. So potassium is particularly important because patients can develop hypokalemia from vomiting and GI losses. And remember that potassium also affects smooth muscle function. So significant hypokalemia can further impair intestinal motility. And sodium and chloride may also become abnormal depending on the severity and duration of vomiting and fluid losses. We may also see acid-base abnormalities, and these can vary depending on what's happening. For example, a patient with significant vomiting is losing gastric hydrochloric acid, which can contribute to a metabolic alkalosis. But if the obstruction progresses and the bowel becomes ischemic, now we're dealing with inadequate tissue perfusion and anaerobic metabolism, and that can contribute to metabolic acidosis and an elevated lactate. And lactate is an important lab to understand here. An elevated serum lactate can raise concern about inadequate tissue perfusion and possible bowel ischemia, especially when it fits with the rest of the clinical picture. However, a normal lactate does not completely rule out early bowel ischemia, so we don't want to wait for the lactate to become dramatically elevated before taking a deteriorating patient seriously. So when you look at the labs in bowel obstruction, I want you to organize them around these three questions. Is the patient dehydrated? We're looking at the BUN and creatinine, we're looking at the hemoglobin and hematocrit, the urine output, and our clinical assessment. Secondly, what has the patient lost? We're looking at the potassium, sodium, chloride, and the acid-base balance. And thirdly, is the bowel becoming compromised? We're looking at the white blood cell count and lactate, but always interpreting those alongside the patient's abdominal exam, vital signs, and imaging. Imaging is important for confirming the obstruction and determining its location and cause and looking for complications. And a CT scan is particularly useful because it can help identify a transition point, the underlying cause, and findings concerning for ischemia or perforation. And the main thing I really want you to take away with this information is that bowel obstruction isn't dangerous simply because the patient can't have a bowel movement. It's dangerous because continued obstruction can eventually compromise blood flow to the bowel. So when you're caring for these patients, you're watching for that transition from the bowel is blocked to the bowel is losing its blood supply. Now we're moving into acute abdomen. And the most important thing to understand is that acute abdomen is not a specific diagnosis. It's a clinical presentation that tells us something potentially serious is happening inside the abdomen, and the patient needs prompt evaluation. So these patients typically present with sudden or severe abdominal pain, often accompanied by other concerning findings, and it's our job to determine what's causing it while recognizing that some causes are immediately life-threatening. So what's happening physiologically? So many causes of an acute abdomen ultimately result in inflammation or irritation of the peritoneum. And remember, the peritoneum is the membrane that lines the abdominal cavity and covers many of the abdominal organs. Normally, those surfaces can move against each other without causing pain. But when the peritoneum becomes inflamed or irritated, maybe from infection, blood, bile, pancreatic enzymes, intestinal contents, or gastric contents, it becomes extremely sensitive. And that's why these patients can develop severe pain, guarding, rebound tenderness, and rigidity. And you'll often notice something about these patients when you walk into the room. They really don't want to move at all. Movement causes the inflamed peritoneal surfaces to move, which increases pain. So the patient may lie very still with their knees drawn toward their abdomen, and that's different from some types of visceral or colicky pain where patients may be restless and unable to find a comfortable position. So visceral versus peritoneal pain, this is a useful distinction when assessing abdominal pain. So visceral pain comes from the internal organs themselves. It's often poorly localized and may feel dull, aching, cramping, or colicky. And as inflammation begins involving the peritoneal the parietal peritoneum, the pain tends to become sharper, more severe, and much better localized. Appendicitis is a classic finding, so early appendicitis may produce vague periumbilical pain, but as inflammation progresses and begins irritating the parietal peritoneum, the pain typically localizes to the right lower quadrant. So the location and character of the patient's pain can actually change as the disease process progresses. So acute abdomen has many possible causes. So looking at how broad the list is, we have GI causes such as appendicitis, bowel obstruction, perforation, pancreatitis, cholecystitis, and mesenteric ischemia. But abdominal pain doesn't automatically mean GI disease. A ruptured abdominal aortic aneurysm can present with abdominal or back pain and hypotension, or an ectopic pregnancy can cause severe abdominal pain and internal hemorrhage. Even diabetic ketoacidosis can produce significant abdominal pain. And kidney and urinary disorders can present with abdominal or flank pain. So we don't want to develop tunnel vision and immediately decide that the patient has abdominal pain, therefore it must be GI. So when we're assessing a patient with an acute abdomen, the presentation is going to vary depending on the underlying cause, but there are several findings that should immediately get our attention. And the most obvious is severe abdominal pain. So we're paying attention not only to the severity, but also to the onset, location, character, and progression of that pain. So a sudden onset of severe pain is particularly concerning because it can occur with conditions such as perforation, mesenteric ischemia, ruptured abdominal aortic aneurysm, or ectopic pregnancy. I also want to know whether the pain is constant or intermittent. So colicky wave-like pain may suggest that a hollow organ is contracting inside or against an obstruction, like we've talked about. Constant worsening pain, particularly when accompanied by peritoneal signs, it's more concerning for inflammation, ischemia, or perforation. And remember that pain can change location as a disease progresses. So appendicitis, again, is a classic example. So they may complain of vague periumbilical pain initially, and then later it localizes to the right lower quadrant. Nausea and vomiting, these are also very common, but they're nonspecific. And what matters is context. So is the patient vomiting because of a bowel obstruction? Are they unable to tolerate any oral intake? How long has this been occurring? What does the emesis look like? Persistent vomiting can, like we talked about, quickly lead to dehydration, electrolyte abnormalities, and acid-base disturbances. So if a patient has significant vomiting, I want you to be thinking beyond that GI system itself. We're looking at the heart rate, blood pressure, mucous membranes, urine output, electrolytes, and BUN and creatinine. Another major finding is abdominal tenderness. Some localized tenderness may help us identify where the problem is occurring, but we're particularly concerned when tenderness progresses to guarding, rebound tenderness, or rigidity. So guarding is tightening of the abdominal muscles in response to pain. So with significant peritoneal irritation, the abdominal muscles may become involuntarily tense, and the abdomen can feel rigid or board-like. That is not an expected finding that we simply document and reassess later. A rigid abdomen is a patient with severe abdominal pain, and that's a major red flag for peritoneal irritation and potentially perforation or another serious intra-abdominal process. Patients may also develop a fever, and fever can indicate inflammation or infection, but its absence doesn't necessarily reassure us. Some patients, particularly older adults or immunocompromised patients, they may also have serious abdominal process without developing a dramatic fever. So don't use fever as your only indicator of severity. And now looking at tachycardia. Initially, tachycardia might occur simply because the patient is in severe pain, but persisting or worsening tachycardia deserves our attention. So we're asking ourselves, why is the heart rate continuing to decrease? Are they dehydrated? Are they bleeding? Are they becoming septic? Are they developing shock? If the heart rate is increasing while the blood pressure is decreasing, that's particularly concerning. The patient may also look pale, cool, clammy, or diaphoretic, develop decreased urine output, or experience changes in mental status as perfusion worsens. So at that point, I'm no longer thinking only about the abdominal problem itself. I'm thinking about circulatory compromise and shock. Abdominal distension, this is another finding we may see, and distension can occur from accumulation of gas, fluid, blood, or intestinal contents, depending on the underlying cause. For example, significant distension with cramping, vomiting, and inability to pass stool or flatus should make you think about bowel obstruction. We may also hear changes in bowel sounds, depending on the cause and stage of illness. Bowel sounds may become hyperactive, hypoactive, or absent, but bowel sounds alone don't determine whether someone has a surgical abdomen. They may need to be interpreted with the rest of our assessment. And one thing I want you to notice clinically is how is our patient behaving? A patient with significant peritoneal irritation often, again, lies very still because movement makes the pain worse. They may keep their knees flexed towards their abdomen and resist movement. So comparing that with someone experiencing severe colicky pain, such as pain from an obstruction, they may appear more restless and repeatedly reposition because they can't get comfortable. So sometimes simply watching the patient before you even touch the abdomen gives you a lot of useful information. And now let's talk about lab testing. So just like we discussed with bowel obstruction, there isn't one lab test that diagnoses an acute abdomen. The labs are selected based on what we suspect and help us evaluate the severity. So a complete blood count, this can show leukocytosis with infection or inflammation. Hemoglobin hematocrit, that becomes important if we're concerned about internal bleeding. The CMP or chem panel, it helps us evaluate electrolytes, renal function, liver-related abnormalities, and the effects of dehydration or vomiting. A lipase, this is important when pancreatitis is suspected. A lactate may be obtained when we're concerned about tissue hypoperfusion or ischemia, particularly something like mesenteric ischemia or shock. A urinalysis can help identify urinary causes of abdominal pain. And for a patient with pregnancy, potential pregnancy testing is extremely important because, again, that ectopic pregnancy may be on the differential. So again, we're not ordering labs because we're looking for the acute abdomen lab. We're asking what dangerous conditions could explain this presentation and what information will help us differentiate them. And now imaging. Imaging depends on the suspected cause. So a CT of the abdomen and pelvis, this is going to be extremely useful for many causes of acute abdominal pain because it can identify inflammation, obstruction, perforation, abscess, and other pathology. But ultrasound is also particularly useful when we're evaluating the gallbladder or pelvic structures, and it's commonly used when pregnancy-related pathology is a concern. It may also be helpful for suspected AAA, aortic abdominal aneurysm. Abdominal aortic aneurysm? Yes, depending on the situation. So that might be useful, along with an x-ray, which has, as we know, more limited uses, but it may demonstrate a bowel obstruction or free intraperitoneal air in certain situations. But the key is that we choose the diagnostic study based on what we're worried about. The finding I don't want you to miss is one particularly important and dangerous presentation is pain out of proportion to the physical exam. So if a patient reports excruciating abdominal pain but initially has relatively little tenderness or few findings on an abdominal exam, especially in an older adult or someone with vascular risk factors, we want to think about mesenteric ischemia. So the intestine may be losing its blood supply before obvious peritoneal findings develop, and that's a patient where we cannot say their abdomen doesn't feel that bad, so they're probably okay. Ultimately, with an acute abdomen, we're trying to answer two important questions very quickly. So what is causing the abdominal pain, and even more importantly, is there something happening right now that could threaten this patient's bowel circulation or their life? So remember that severe pain plus rigidity, rebound, or other peritoneal signs, and hemodynamic instability or GI bleeding, persistent vomiting, fever with deterioration, or signs of shock.